Today, we'll discuss what PDA is and look at the angiography of a patient with this condition. PDA, or Patent Ductus Arteriosus, is a condition where a thin bridge vessel between the aorta and the pulmonary artery remains open after birth. While this vessel is open in all babies in the womb, it typically closes within days after birth. However, in some children, it stays open, creating a burden on the heart over time, increasing blood flow to the lungs, causing heart enlargement, and requiring treatment. For this reason, we performed an angiography on a patient who was referred to us. How do we perform the angiography? We see our patients 1 week in advance. We conduct anesthesia checkups. We check their teeth. If the teeth are healthy and clean, the patient is considered suitable for the procedure. Then, we admit the patient to the hospital either the day before or on the morning of the procedure. Next, we take them to the angio suite, and since our patients are young children, we usually perform the procedure under general anesthesia, sedation, or intubation. Our patient here was one such case. This abnormal structure was detected in their heart at around 6 to 8 years old, and they were referred to us for an angio. We brought our patient into the angio suite. After they were asleep, we inserted a cannula into both an artery and a vein. By passing tubes through these cannulas into the heart and performing injections, we visualize the heart and this abnormal vessel. In this first image, we see our catheter entering the aorta and the injection being performed. As we can see here, there's a thin bridge-like structure between the aorta and the pulmonary artery. The second step is to pass a wire through this structure to reach the pulmonary artery. This establishes a passage through the bridge vessel between the aorta and the pulmonary artery. Of course, our technique can involve an arterial approach or a venous approach. We decide on this based on the size, type, shape, and location of the hole. Sometimes we proceed through the vein and other times through the artery. This was a patient where we chose to use the arterial approach. As you can see, after the wire passed through, we inserted the catheter and the delivery tube for the device into the pulmonary artery. We chose to use a 3-part device and opted for the arterial approach here. After deploying the first part inside the pulmonary artery, we pulled the device back. We deployed the second and third parts within this abnormal structure and the aorta. Then we verified it with an injection. The key here is to avoid creating any narrowing in the aorta or the pulmonary artery, because if that happens, we might need to remove the device or perform a balloon procedure during follow-up. After confirming everything was correct via both angio and echocardiography, we released the device as you see here. After releasing the device, we conclude the procedure by performing an injection and checking the pressure. As you can see here, our device is in the correct position. There is no pressure gradient between the upper and lower parts of the main artery. The hole is almost completely closed. Of course, there appears to be some passage due to the flow of contrast under high pressure through the device, but these will disappear within 24 hours. Then we remove the cannulas from the patient's artery and vein. We then wake the patient up. To keep a close eye on them, we monitor them in the coronary ICU for about 1 to 2 hours. Once the patient is awake, we transfer them to the ward. We provide follow-up care in the ward for about 1 day. This is so we can monitor for any complications such as bleeding or narrowing in the pulmonary or main arteries, as we discussed before the procedure. After performing an echocardiogram the next day, we discharge the patient home in good health. I wish you healthy days.